Tammy. I really appreciate your comments, and I appreciate you hosting this event. This is a project that has been underway for a long time. We've been planning for 6 months to bring this event to everybody, and we're very happy that it's here today. I'm really happy that our presenters are here, and we hope it's a productive day. My understanding is there's about 100 of us here in the room, and as many of you know, we are webcasting this conversation, so hello to those coming in virtual electronically. We think we have about maybe 400 people watching. I know we have people as far away as Alaska, and I'm assuming the rest of them are dispersed around the state. That Alaska group got up awful early to see this, but we're happy they're here. We did plan the day that the morning would have more of a clinical focus, more provider focus, and I'm going to talk about family engagement primarily. Matt's going to talk about suicide risk assessment, and David's going to talk about pharmacology and management in primary care. The afternoon is going to talk more about systems models, state-level projects that are going on to try to integrate behavioral health into primary care. Some of the work that we're doing here with a Garrett Lee Smith suicide grant, some of the work going on in Pittsburgh, and we're lucky to have some folks down from Massachusetts who have a very creative project going on and really leading the nation in some innovative ways. So we hope the day is productive and interesting for everybody, and the webcast people can call in. They can write us questions. If anything interesting comes up, Matt will let us know and share it with the group. I am here at CHOP. I'm the director of the Center for Family Intervention Science, an associate professor. This year I happen to be visiting professor over at Drexel, helping them with a family therapy program, but still connected to the department. And let's get started. I'm not going to present a lot of suicide data. Tammy presented some good things. I know Matt's got more, and I'm sure all the other presentations. But certainly people should know in the latest data, this Knox study in 2013, the suicide estimated rates of contemplation are still pretty high in a general population. 4% are making a plan. 4% of kids are making attempts. The sad news is only 14% of kids with suicide ideation and 22% of those who've made an attempt report receiving mental health services for this problem. And it's really this kind of public health problem that has led a lot of interest in, can primary care become a gateway, an opportunity to identify youth who are at risk before an attempt, early intervention, early assessment, and prevent some of these problems. There's a similar interest in the emergency room environment, lots of research and studies going on there as well, but today we're going to talk primarily about primary care. Just one thing that's also worth saying is, unfortunately, the rates of suicide in minority groups is also increasing. And it used to be, for instance, African American kids had very low rates of suicide, but now it's also the third leading cause of death in blacks and Hispanics, and they really match those of their Caucasian counterparts in adolescence. So suicide crosses SES, it crosses ethnicity, it touches lives everywhere, and really is a serious public health problem, and I'm glad we're here to try to address it. What's Pennsylvania been doing? I'm going to talk more about this project in the afternoon, but just in brief, so you know, we have a SAMHSA grant. Garrett Lee Smith has money. Each state in the union can submit for a SAMHSA Garrett Lee Smith grant and do some kind of suicide prevention work across the state. Most of the projects are in schools, public health awareness things. Pennsylvania's been the primary state doing work in primary care settings, and that's actually gaining some traction, and other states are trying to do the same. We have 5 aims to the grant. We know, as many of you, that merely introducing a screening tool does not quite solve the problem. The ripple effect of that is tremendous. Physicians feel like, I'm going to increase identification rates. I don't feel comfortable talking to kids about suicide. I don't have places to send kids for suicide. I don't have time to screen them. So it has multiple kinds of problems. So our project attempts to try to address it, both creating stakeholder groups, primarily increasing coordination between medical and behavioral health communities, and that's been quite a long story I'll talk more about in the afternoon. We've been doing gatekeeper training. Matt Winterstein's going to talk about a version of that today. And the center of our work has been a web-based screening tool that solves a lot of interesting problems for primary care. The project is run through the State Department of Public Welfare. Stan Modowski is the director of the project, and they contract to us, to CHOP, and to Jefferson, where Matt is, to do most of the work. So there's really a nice team of people doing that. I'm going to talk a little bit about the screening tool. I know in the description I was going to cover a few other tools, but I actually found myself writing a lot more about family engagement. It's an area we've been wanting to develop more. So I'm just going to run through briefly the screening tool that we've developed and are using in our project and some of its strengths and benefits, and then turn to once a kid's identified, how do you talk to a parent about getting them to take the kid to services? This is one of the biggest gaps in the continuum. We can identify the kid, but will they go? What are the family level barriers that keep them from going to services? So the screening tool is an interesting one. It's been designed to reflect many of the values and areas that are encouraged to be assessed by the American Pediatrics, American Psychiatric Association. It's a web-based tool. It covers a broad range of things. It takes about 7.5 minutes to do. It generates a report. Once you complete the tool, the report prints up in the nursing station. The provider picks up the report before going into the interview and says, what kinds of things should I be focusing on? It's meant to help streamline a psychosocial assessment, not make it longer. It does interface with electronic medical records. An interesting thing for us is that the data can be aggregated both within a shop, within a medical site, or across sites, or throughout a medical institution like a hospital, or even across state. We now have over 15,000 screens that have been done across Pennsylvania, and we have access to that data and are able to look at trends and changes in different environments and use it for QI purposes and research purposes. And the tool is now in English and Spanish and Chinese. There's an interest in China in the tool. It's kind of nice. These are the domains that it covers. We designed the tool to reflect our experience was that pediatricians and medical providers and outpatient PCPs were well-versed in risk assessment behavior. That was a language they used, and less comfortable with psychiatric syndromes and diagnosis. That was a domain. So we tried to keep both those languages and domains alive in the screening tool and cover a number of risk behaviors, but also gave them scales that could allow them to rapidly assess some of these main domains. This is what the tool looks like when a kid's logged on. The questions are nice and big. There's yes and no. They're clicking through. We all know kids like doing screening tools online. We all know from the research that kids prefer using a screening tool to talking to a provider. They tend to disclose more things on a self-report tool, knowing it's going to go to the provider, but as a stepwise progression, it tends to make them feel comfortable, a little more the privacy. When the report comes up, this is what it looks like. You can see there's a place for critical items, comes to the front. Suicide, psychosis, sexual abuse would pop up on the front screen so that a provider would right away know, oh, these are urgent things I need to do something about today. Then there's scales that have clinical significance. So you can tells you is depression moderate, high, severe, give you some clinical guidelines. It brings up risk behaviors, things that are worrisome, but maybe you say, come back next week, I want to talk to you about you're in a car where people are drinking. And then we also have patient strengths. These are some of the places in Philadelphia region that we're in. CHOP's emergency room has been doing this for about 7 years. We're at several healthcare centers that are part of CHOP. We're at Jefferson. We are in St. Christopher's Hospital now. We're in 3 emergency rooms, including the psychiatric emergency center for the city that sees about 1,000 suicidal kids a year and does most of the psychiatric evaluations. And so we're really kind of have done a nice penetration into here. In addition, we're in a number of other counties, including Allegheny and Montgomery and out in Westmoreland out west. So the project's going well. Here's some of the kinds of data that you get to see. So at Chestnut Hill, our friends are here. They've screened, this has been going on for about 6 months. They've screened about 170 kids. It's interesting how different clinics use the tool. Some say we're going to try to do this universally and do everybody, and we have a site up in north of Scranton where she screens 20 to 25 kids a week. Everybody, she's just committed to doing that. Other sites use it more as indicated screening. I'm worried about Johnny. I've been worried about him a long time. Have him do that tool when he comes in. So it can vary. The penetration rate can vary. Out of the 170 that were screened at Chestnut Hill at CHOP's outpatient site, 26 had some kind of history of suicide, reported that. 86 said they had a history of depression. You can see 40 said reported some level of trauma. When we get a little closer to the data, what we see is of the 86 who said yes to depression, about 21 report at a severe depression level. These are kids that really need an evaluation, need services, who most likely would have been overlooked, not interviewed, and not seen. It is similar with suicide ideation. We ask a question about lifetime. Ever in your life thought about suicide and currently thinking about suicide? Our data suggests that kids who have never thought about it are doing functionally better than kids who have thought about it in their lifetime. If you've thought about it in your lifetime, you're much more likely to have a number of other risk factors, depression, substance use, family conflict, as opposed to those kids that are currently thinking about it obviously have a lot more severe symptoms. So a lot of the suicide measures that are out there, a lot of the depression measures that are out there, ask in the last 2 weeks, have you felt this way? And our experience in primary care is these kids are seen once a year, and a 2-week window may not reflect really how they're functioning over the last year. They're all coming in the end of August for a well visit. Summer's been great, I'm feeling fine, but last May I was depressed and suicidal and doing drugs and things like this. So we've tried to discriminate in there. But we do find in the Chestnut Hill and the second one, out of the 26 who said suicide, 4 of them had current suicide. And I don't know if you think, you feel like that's identifying more kids than you used to? Or we have our Jack, is there any sense that that's increased rates of that, or just helping solidify what's there? Yeah. Yeah, they've always been, right. That's our sense. A kid, suicide, severe depression, these physicians, medical providers are generally going to find it's really the more early intervention kids. This is pretty severe, pretty mild, multiple risk factors going on. I didn't know about it before. These are the kids I can now refer to services. So it's been a good project. The tool's gotten a lot of interest and has a lot of value. And we're very excited about it. But it's only one piece of the pie, and that's how our project has operated. And what I wanted to talk about today was a little bit more about once you identify a kid who's suicidal or severe problems, one issue is, what do I say to the kid? He reports this on the screen. How do I talk to him? How do I open up a conversation that makes him feel safe and comfortable? Is the mom in the room, not in the room? These kinds of things. And Matt Winterstein's really going to cover a lot of that in great detail. We have a great training for primary care on that. Today, what I'm going to talk about is, what do you say to the parent? How do you deal with them? How do you motivate them? I'm sure all of you in the room have sat in front of a a whole range of parental responses. Some parents are concerned and worried and ready to do something. Some parents are in denial. Some parents are indifferent. Some parents are too overwhelmed and can't really take this on. And so we just wanted to kind of talk through that territory a little bit, give you some pathways to think about what could I do, how could I try to motivate them. Our view is, there's been a lot of good work with motivational interviewing as a way to intervene at this moment, but most of it has targeted the adolescent. And our experience is adolescents don't decide to go to outpatient psychotherapy. It's just not going to, that is an argument I'm never going to succeed at. Parents take them. And the parent is really the vehicle to get these kids into services, and that's where I need to invest the bulk of my intervention strategy. There's a lot of talk about barriers to services. There's a lot of literature on this. It's very helpful. I'm going to go through some of these things. A lot of them you've experienced, but it just helps to give you a kind of template, a platform to sort of think about what are the typical kinds of things I'm up against and which ones of them do I have to talk about now, later. Some parents I have to focus on this a lot. Some parents I focus on this a lot. So logistical barriers we're going to talk about psychological barriers. What we're going to talk a little about today is the quality of parent-child relationship, because that's going to get in the way. If there's tension between them, kids are going to be much more resistant to parents' attempts to bring them to services. And obviously there's systems levels of care, barriers that we'll talk more about actually in the afternoon. So what are some of the logistical things? We know there's, particularly for those of us that work with more low-income families, there's issues of transportation, childcare, scheduling. These are not small issues. Parents are working. They can't get their kids to these places. This is the domain that's most often discussed to help with families. So there's lots of protocols now to sort of do resource evaluation. Let's walk through this. Let's think about what are the things that you need to get you to the services. And this is a domain that I think many people are familiar with. For adolescents, we often find particularly, some of these kids, more higher functioning kids, they're too busy. I'm in football, I'm in school class, I can't go, and sort of challenging them. We had a girl, that we evaluated recently in our intervention study, and severe suicidality. And this girl just had to go to, we just had to get her into the ED and probably admitted to an inpatient unit, but prom was next week. And the parents like, well, she's been waiting so long for prom, can't we just wait a little while? And the family ended up taking her home, and she went to prom and came back the following week, and so there's these, they present certain kinds of challenges in these as well. What we want to argue today is that offering case management services is often not enough. It's often essential, but it's not necessarily enough to address what we think are sort of some of the background psychological barriers that really get in the way of kids going to services. So what are some of the things we think about for parents about psychological barriers? We know from the literature one of the biggest reasons kids don't go to services is parental depression. When parents are depressed, it's hard for them to get organized, it's hard for them to get out of bed, it's hard for them to stay motivated. Kids don't really want to go. Parents don't have the wherewithal to try to get them motivated to go. So it's a very common, certainly depression and other psychopathology in parents. There's a lot of issues about stigma about mental health. A lot of people don't feel like that's for crazy people, not for me. We know this territory, and in fact, this is one of the reasons there's a strong interest in integrating mental health into primary care. Primary care has much less stigma. It's much. You've seen your primary care doctor. These kids have seen them, known them all their life. They feel comfortable. There's a stronger alliance with the primary care setting, as opposed to the mental health center, where there's adult schizophrenics and the substance abuse clinic next door. Kids walk into those environments and feel like, this is not me. I don't want to be here. I'd rather go back and see my pediatrician. So that's one of the powers of primary care, certainly to do identification. There's a lot of interest in, obviously, co-locating and integrating. We're going to hear more about that today. So stigma plays a big role, may or may not be something that needs to get discussed with parents when thinking about referring. A lot of families have had negative experiences with services. They've gone, they haven't liked them. We unfortunately know community mental health services can vary in the quality of what they have to offer. There's long waiting lists. There's high turnovers in staff. So they go to those centers and feel like, I really didn't get the kind of services I want here. I'm reluctant to go back. And sometimes we need to sort that out with them. If we sense that's part of the hesitation, that's worth discussing. A lot of parents feel very helpless. I don't really know what to do. I don't know what the problem is. They're just very confused, sort of overwhelmed, and that needs to be addressed as well with many of the patients. And a lot of them feel very hopeless. I've tried, we've been before, nothing's worked, I've given up, I can't help this anymore. And to ignore those impulses in parents is to miss out on the clinical opportunity. You can't say, here's an address and here's a place to go and you should do that, right? You're good to go, and not say, well, I can see how despaired you are. I can see how overwhelmed you are. That's what we're going to talk about more. So we're going to talk a little bit today about sort of procedures for how to get into this domain to some extent so that you can fortify and bring that up so that it won't become a barrier to solving the logistical problems. A lot of parents feel quite burdened by the illness of their kids. These kids, we're talking some pretty high-end kids, multiple hospitalizations. We have a suicide grant going on. These kids are multiple, hospitalizations, treatment courses, failed this and that. These are very complicated kids. There's certainly kids in the middle who've never been to services but are difficult at home, cranky, irritable, hard to get along with, withdrawn. The burden of illness can either be a motivation or it can also be a deterrent. Sometimes this is so overwhelming, parents feel like I have to do something about it. And sometimes it's so overwhelming, I'm fed up and I'm done. And you really have to kind of figure out where the parent's at that level of how much the burden is on them, how much stress do they feel, is that motivating them to get services, or is it sort of making them feel like they want to give up? Another issue that we come up against is beliefs and attitudes about mental health. And these are very helpful domains to have conversations with families about, even if they're brief conversations, because it gets at the parents' attributions about the problem. And the way they think about the problem often influences what they're willing to do about the problem. So if you just focus on do but don't try to understand their attributional models, sometimes you're up against things that you need to address more directly. So lots of parents, particularly with suicide, tend to minimize. This really isn't a crisis. It's not that bad. He's just looking for attention. How many people have heard that one before? This is just, right, this is just, he's like this all the time. And that's a problem. That's going to reduce their motivation to try to go get services. A lot of parents see it as a moral issue, that he's just weak. He's got to toughen up. So what if school's bad? So what if there's a little bullying? I've just been, and there's a sort of lack of empathy for some of the struggles that kids are going through. Some parents attribute it to personality. This is the way he's been. He's always been like this. He's just a, overly sensitive kid. And that tends to distance parents from, I can't change. If it's personality or if it's biology, he's just like his father. He's depressed like his father was. That's an attribution that says, I can't really influence this. Right? I can't change his personality. I can't change his gene set. So it's a more distancing style. A lot of parents feel like my job is over. I've done the parenting. He's 16. He's grown up, right? David's laughing. Yeah, but a lot of parents feel that way. This is just, I'm through with it. He has to take care of it on his own. That's an attribution we have to go after. That's something we have to find out how to challenge. We're going to talk about. There's also issues with ethnicity and race. We know a lot of low-income families you have to use the public health system. The data typically says that it's not ethnicity or race that is the predictor of not going to services. It's really low income, low SES. So it's not the racial factor. Though there certainly is a history in the literature about minority families being suspicious of mental health providers, being suspicious of medication. For a long time in our work here in Philadelphia, the African American kids were rarely on medicine as opposed to the Caucasian kids who were much more likely to be on medicine. There was a lot of skepticism in that community about using medicine. So there are certainly issues that one has to think through, cultural sensitivity about trying to evaluate what's going to make it hard for this mom to go to services or not go to services. And it's a dimension that should be thought about, if not discussed openly. There's also barriers for the adolescent. They tend to minimize the distress. They're hopeless about services ever helping. They're worried about shame and stigma. I don't want to go to that place. That's for crazy people. That's not for me. I'm not that bad. And many kids tend to be resistant to parents' attempts to help them. Parents want to, I'm going to take you. No, you're not. I don't want to go with you. Though one thing we find is depressed and suicidal kids actually are would welcome parent engagement and parents taking charge and trying to provide services. These kids tend to, underneath their depressive mood, are really seeking relationship. They're much more, as opposed to our more sort of conduct disordered kids, and substance abuse kids are sort of somewhere in the middle of it. But the suicidal kids, particularly if they're disclosing in your office, they're disclosing because they want help. They know they're unhappy. They know they're hurting. And we find, even if there's a lot of bravado or denial, that underneath they're really grateful that somebody's finally going to take charge and do something and try to help them out. So we try not to get discouraged by their presentation and just sort of try to move underneath to what we think are really their deeper motives. Obviously, at systems levels, there's all kinds of barriers: access to care, poor insurance coverage, turnover of staff at the agencies, poor quality of services sometimes, and particularly a lack of communication between providers in the mental health setting and in the medical setting. Jack's been spearheading some work here to try to forge stronger relationships between primary care and the local community mental health environment, and it's remarkable how disengaged they are, how separate they are, a lack of communication, and the afternoon talks are going to talk more about sort of solutions for some of them. Sometimes parents are the problem. We're not naive. A lot of suicidal kids are coming in. In our studies, about 80% of the kids attribute conflicts with their parents as one of the three primary reasons they're feeling suicidal. So one has to think through, if I'm going to bring the parent into the room and they are the perpetrator of some of this stress, how am I going to handle that, and is this the best approach? Particularly when it's even in the more severe range of abuse, neglect. Kids are reporting, my father's sexually abusing me, my mom's an alcoholic. These things are much more complicated, and us as providers have to think more seriously, how do I bring the parent in? Do I bring the parent in? Some kids don't want you to tell the parents what they said. They're afraid of reprisal when they go home. So these things have to be thought through sensitively. Often we're calling DHS for a consultation. Look, this is how we're seeing things. You know, is this a case you'd get involved in? And trying to think through, you know, what's the best way if we really think that safety is an issue. That's not the predominant scenario we see, but it's worth it. You have to have it on the back of your mind when evaluating these cases. So those are some of the problems we're up against. I'm sure you're all seeing them. I'm seeing enough nodding heads to say, yes, I've seen that, I've struggled with that. And you know, what I'm hoping is that sort of little overview gives you sort of some handles on how to dismantle. You get a parent in front of you that's stressed and resistant. What are some of the things I should be thinking about? And that's sort of how we think about it. Stigma, attitudes about mental health, stress, psychological pressures. But how do we win them over? How do we sort of cut through some of these sort of barriers and resistances and try to find how to reactivate some motivation in parents so that they'll say, okay, I'll make the call and I'll take them to treatment? That's really what we're looking for. We're not looking to solve all these problems. We're not looking to resolve the parents' depression. We're not looking to fix access to care. Well, some of that we are. It's really, how do I activate enough motivation in the parents to say, okay, I'll take them? There was a study by Jackie Phelan in Cincinnati where she did evaluations in the ED, did a DISC, found kids at the level of disorder and provided free psychiatric care in the psychiatry department in the hospital. Look, here's an appointment. You can go next week. They'll see you immediately. 10% went. 10% of parents. I mean, she didn't dismantle some of the reasons why. She's done great work in that area, but the kinds of things we're talking about kept them from going. It's not that bad. I'm too overwhelmed. I can't get child care. I mean, there's all these sorts of things. So what's going to help cut through that other than trying to solve some of these things? What we want to argue is starting with, as I said earlier, the logistical barriers is not the best place to go. That we really want to offer you a strategy. Really, what we're going to talk about today is really more of a therapeutic moment. I'm not trying to turn you into therapists. I'm not trying to make you do family counseling. But I think there are some therapeutic procedures that are often overlooked and in some of the sort of protocols about how to deal with these situations that you as providers, because my experience with primary care providers is you people are actually pretty wonderful with these kids and really do a great job and are very heartfelt. And I'm just going to give you a few sort of strategies to how to focus and organize a conversation that might help activate a sort of motivational level that would enhance the possibility that they go. We haven't studied this yet, so I can't come to you and say it's a sure bet, but that's what we're interested in doing. Some of this is going to be simple. It's what you do all the time anyway, but we're just going to try to organize it in a way that it has a sort of structure and protocol to it. And obviously what we always talk about first in a counseling center is listening first. Don't teach, don't offer solutions, just listen. That is sort of the core number one principle in a therapeutic environment. There are studies to show that the more therapists tend to teach, the more resistance parents tend to have. Some old studies by Gerald Patterson and stuff. But teaching tends to be pedantic. It can border on people feeling insulted. It can be off-putting. What we try to do with it is slow it down and try to draw out the story from them. So we spend a lot of time trying to listen to them, express their concerns. We try to explore how much of a burden their child's problems are for them. We try to understand we try to find out how they understand or explain the story. And sometimes we even listen to their own problems, their marital problems, their depression, their inability to find services themselves, their unemployment. And this could be a 5 or 10-minute conversation, which I know is complicated in primary care, but you're going to spend that much time with this family anyway when you're trying to make a referral for a suicidal kid. We're saying start with a moment of listening and empathy with these parents so that because they're walking in and anticipating that you're going to blame them for the problems, that this is my fault and that I've done something bad as a parent. That's how many of our parents sort of walk in the door with their guard up, anticipating that. And we try to instead understand from their point of view what they're up against, what they're struggling with, and try to acknowledge and punctuate that. So at the end of this short conversation, we say things like, wow, there's so much up on your plate. I'm not surprised that you're struggling with Sally, and in fact, I'm impressed that you're still hanging in there with her. We try to let them vent, make them feel understood. Don't try to change their mind at this moment in the conversation. Don't get into an argument with them about their point of view. We just try to let them present and make them feel listened and heard. Ooh. When we feel like there's enough of that on the table, there was a study done in Australia where the family treatment for kids with anxiety, and they put in a 15-minute module, where they sat down and said to the parent, how are you doing? I know you're here for your kid, I know you're here to help him, but what's going on for you? Wow, that's a lot. This is hard. I can see. Maybe we can help you find services. Maybe we can try to make a referral. Boy, that's tough. Now let's get back to work. And those cases did much better engagement. Stayed in treatment longer, got better outcome. And this is what I'm talking about, just a small moment of them as a person trying to understand some of the stress that drives some of their problems. What we're trying to do is activate strength in them so that their stress, their difficulties that they're under, their inability to help their kids, but yet their ability to hang in there. You're here today because you want to help your kid. That is amazing. These parents really, particularly when we're working with inner city families, they're having a much harder time. I'm married to a woman who's a psychologist. We have a nice home. I got a couple kids, and I'm overwhelmed. Imagine being single and depressed and trying to raise 3 kids. And that's the kind of moment of empathy we're trying to connect with these parents. And we're trying to turn the conversation from you're doing something wrong to you're really a hero. You're doing an amazing job. He's so lucky to have you. And I'm telling you, these parents never hear this. They don't. They're not viewed that way by the schools. They're not viewed that way by DHS. So a moment of acknowledgement of how the heroic effort that they're putting in to try to raise their kids moves from that you're not a failure, that this is actually a strength, that you really have some tremendous capacity here. So rather than them feeling that they're blaming them for the problem, we don't want them to feel that we're blaming them. We want to help them feel understood, affirmed, and respected. 10-minute conversation can do that. Clear acknowledgments from you of admiration and respect for what they're going through. Then we try to move to a yes. With that in place and that story told, it's easier for us to try to modify their description of the story in a way that helps them see that the inevitable solution is to go to get services. So we say things like this. So clearly, you're very worried about your kid. It's an amazing how committed you are and how much you love this kid, right? And we try to get an agreement. And you're telling me he's been depressed and difficult for a really long time, right? And they say, right. And you feel like you don't know what to do. You've said you're just overwhelmed. Things that you tried haven't helped, right? Yes, I guess that is how I felt. I did say that, didn't I? And you're doing this all on your own. That's amazing, but it's difficult, right? Yeah, it is kind of difficult. I hadn't thought about it like that. There's a lot of burdens on you. So suddenly you take their story of stress and difficulty and kind of repackage it in a way that says, I really need some help. Unfortunately, some of my last slides got cut out at the end. So at that point, it's much easier to say, well, we talk about closing the deal, the sort of moment where you're going to sort of, up until now, we haven't asked them to do anything, right? It's all been about reflection, admiration, connecting with them, helping them decrease their defensiveness. We often will turn to the kid at that point and try to read how are they feeling, how are they responding. When kids sit silently, we don't put pressure on them to talk. Our experience is a kid sitting silently is listening very intently, and that this is going in. And I don't need to challenge them or evoke anything out of them. This is working for them. And it's not always the case, but it's the way we think about it. Some kids say, I don't want her help. They'll continue to express denial and indifference. And we very clearly say, and it's going to come out of Matt's conversation, we turn to them with all of our confidence, empathically, but with authority, and say, I really don't believe you. It's so clear how unhappy you are. You're failing school, you're feeling depressed, you reported that you're thinking of hurting yourself. You can't tell me that life is going well. And you deserve to have a better life than this. And that's what we're going to try to accomplish today. So we just don't let the kids' narrative dominate the story. We come in directly and counter it with our professional, empathic position and say, no, that's not the story here, that you're indifferent and don't care and don't want to help. That is not the story. The story is you're in pain and you need help, and you have a story to tell, and you deserve for that story to be told. With that little piece in place, we can move back to the parent and say, look, I'm really worried about you. This boy won't survive without you. That's a very different statement than what they come in thinking. This boy needs you. I'm just worried that you're getting burnt out, that you're doing this all on your own. And what I'd like to do is try to expand the team. I'd like to give you a bigger team. I'd like to be on the team, and I'd like you to go, if I could, down the hall to see Dr. Jones. I got a great psychologist. This is the value of integration, or now Jack can say, look, a couple blocks away, we're working with a counseling center. I got great people there who can help you with these things. You are doing a great job, and you deserve more help. Would you be willing to make a call? Sometimes, could we make a call right now? I know some offices at CHOP have social workers, so you can, sort of turn to that. We're going to have that. But that's the sell. That this is, you're doing an amazing job. I'm worried you're going to get overwhelmed, and I want to expand your team so that you can try to have some resources and help accomplish the things that you want. You want this kid to do better. You want him to be succeeding more. And hopefully we get a yes. Now, sometimes what our experience is, at that point, it's a different kind of conversation. The logistical barriers become problems to solve rather than excuses about why I can't do it. Because I have changed their motivational stance. We talk about this as a sort of attachment activation. I'm an attachment-based researcher, and that we're resuscitating their instinctual desire to help their kids. And we say that, actually on my one slide here, some parents, even at this point, say, well, you're crazy. I don't have any influence on this kid. I can't affect him anymore. And again, we hold on to our narrative. We don't let that narrative dominate the conversation. And again, we say, I don't believe that. And your son is hurting, and he needs your help. And we remind them of their youth. When your kid was little, and he would have gone to the stove and put his hand near the fire, you'd have flown out of your chair and stopped him. You would protect him. That's what you parents do. Dave.
I didn't say no either.
What we say is his hand is burning now. He needs you. He needs his mother to protect him. And taking him to services is one way to do that. So that the whole frame about the referral is about love and protection, not punishment, punitive, It's not a power conflict. This is what parents do. And we're trying to touch that part of parents that feel like, oh my God, you're right. I do love him, I am worried about him, and I'm going to do something about it. Here's one thing I can do. Jack McGee is telling me how to take care of it. So we're trying to activate their caregiving instinct, but you have to go in and see it in them. They have forgotten, and most of the people in the system never attend to it. And that's my little sort of parting gift for you. That's the goal of this conversation, that you as providers can see in them the strengths and capacities that they have, and if you speak to that part of them, that will come out. And the parts that are about no will start to diminish, and the conversation will be more about love, protection, and help. And it's with that level of motivation, we find parents are more open to solving the problems that are going to get them to care and taking kids to care. Thank you. We got a couple minutes, so questions, I'll repeat them.
Maybe you've already done this, but have you thought about putting these techniques on video so that people could learn it? Because I think that it's naive to think that somebody can do it as well as you and Harry, but I think that even if you could have somebody as a surrogate, kind of throwing out some of the common barriers.
Yeah.
The answer, I think, it would be enormously useful.
Yeah. So David's question really is, how hard is it to learn this? And can't, yeah. And that's, I think it's we teach it all the time. And David's thinking a videotape that could kind of demonstrate, and definitely have thought about it, and something we'd like to do to try to, what we try to do is give you phrases that, and sort of like this, would kind of guide you through this conversation. Obviously, every case is going to be different, and there's always challenges. Every family presents differently. But these are learnable, and David's going to give me a small grant to build a videotape and train me. Everything's about grants, It's,
Good morning. I'm Mike Federico with ERT. Have you had any luck demystifying the whole mental health and bringing it out of the darkness by comparing it or giving the parent something that they can compare to with other chronic illnesses, if it was an allergy, if it was diabetes, if it was any sort of autism or anything like that? Have you had any luck in comparing it to other things that they might be able to relate to, and their fear of the unknown maybe is, and an ongoing sentence is what they feel like they're up against?
Yeah, I think it's a good strategy. We to try to, sometimes we will compare this to a medical disorder. I know, like, for instance, the substance abuse field has worked hard to define substance abuse as a medical disorder, because medical disorders we're all committed to, and that's something we can help and do something about. These psychological things are much more murky and hard to understand. So it's not a bad metaphor. Look, if your kid had diabetes, you would get him to the hospital and get these shots, right? If you're, that's what we're talking about. This is a problem that you can solve. So I think it is a nice metaphor that helps some families think about it differently.
Hi, I'm a social worker in primary care at CHOP, and when you were talking about this conversation of getting the parent to yes, I was wondering if you feel like it's really crucial to the process to have the child present for that whole conversation with the parent. I think sometimes the parent's complaints about the child can be so brutal, and my instinct is often to try to let the kid step out while the parent just, the litany of complaints. But I was interested in your description of the child intently listening at that point, and whether that's really key to the process or not.
This is, again, a moment of clinical judgment, which you guys, I'm guessing, make all the time already. This is a parent who's so negative, who's so difficult. I'm going to see them alone for a few minutes and see if I can't. I don't want the kids sitting there hearing that, so I'm going to do it separately. This is a parent who's, sort of mid-range, ambivalent about what they're thinking, and I want to do the process, because what I do with the parent, I don't think is insulting to them. I think if a kid watches that, it's actually reinforcing a similar message. Your mom cares about you. I know you think she's over-controlling, but the truth is she's there for you in ways that if you didn't have this, you wouldn't be here today. So sometimes there is a sort of way of a double message by having them both in the room and the advantages of that. You just have to sort of watch how the clinical management of it goes. You have to be, for particularly, we do this in a therapeutic setting, and we have a little more freedom and a lot more time. When we're doing this in a medical setting, you really have to control this conversation. You cannot let it get out of control or expand into too much negativity, and so it's all. I think there is value of having the kid there. I think there's a power. Actually, my one slide didn't go away. A powerful moment, if you wanted to be a little more risk-taking, is at that moment when you've got the kid sort of a little more vulnerable and a little more admitting that they want help, and you've gotten the parent in the right place, you can turn to the parent and say, it's amazing how much you love this kid and how committed you are. I know it's a bumpy road, but you have an amazing commitment to this kid. I sometimes worry that Johnny doesn't know that. And what we do in therapy is we say, and I think I've seen us do in medical science, I wonder if for a minute you could turn to him and let him know. Could you turn to your son and tell him how committed you are and how worried you are about him? And then what you're doing there is engineering a moment of a certain kind of narrative where, I know there's 1,000 other problems going on, but what's gotten forgotten is I do love you, and I am committed to you, and that's why I'm taking you. And that little moment of interaction between people, that can go a long way. That's a profound moment to engineer that kind of moment of intimacy. It's a little more time, a little more risky, depends on the family, but so I think having them both in the room has great potential to create a moment, a powerful therapeutic moment that I think is sometimes can be really valuable in an ED setting when these families are in such crisis or in a medical setting. Yeah.
Between, like, 2 follow patients, blank space, 2 more follow patients, because I know something's going to come up.
Yeah.
And this is as much as you want to say it's 10 minutes, it's a heck of a lot more than 10 minutes when I'm there doing it.
Yeah.
Because it can take up to an hour with some of these families who are in such incredible stress.
Right.
And to push through all of that, I've had it, or she doesn't love me, and all of that is just phenomenal.
Yeah. So the question is, in a busy medical practice, do you really have time for these things? And I guess our experience is with suicidal kids and depressed kids, you're taking this time anyway. That's what providers say. You know, one of the ambivalences about screening is, my God, I find a depressed kid and suddenly my whole day gets thrown off. So our experience is you're doing this already. You're already crushing your schedule and taking up time with these kids. What we're trying to do is give you some tools to how could I use that same 15, 20 minutes more efficiently. So that's how we think about it. But I'm not naive to the realities of, you know, I've been working in primary care now, 10 years, and it's a challenge. It's definitely a challenge. My heart goes out to you. That's why we need more co-location, which we're going to hear about models of that. You should all have social workers, psychiatric nurses on the units, and that's what we're hoping. What we'd like to show is if we could early identify kids with mental health problems and get them early services, that it could reduce medical costs. We know depressed kids are one of the highest consumers of services in emergency rooms. That's where they end up. They recycle through emergency rooms. So if we could do mental health intervention more easily, more quickly, we could reduce those costs. I could reduce sending kids to the emergency room. I could reduce inpatient admissions. That maybe Blue Cross would say, this is actually a pretty good thing. Maybe we will, let you bill for a social worker. That's the argument that many of us are trying to build, and I'm meeting with them, Blue Cross next month, to try to win them over and make that case. But that's a tall mountain to climb. So, all right, I think we're going to stop there. I'll take questions. Anybody wants to come up, and I think the slides are all available. I can get you a little more detailed version of the slides. Matt, do you know, are we taking a break here? No. So I'm going to turn it over to Matt. He's going to talk about talking more to the kid, kind of do an evaluation with the kid, a little bit about parents, and then we'll have a break after that and then come back to David. So thanks very much. I hope that was helpful.